that we have nowadays. And also it brings a little bit of science to the talk itself. It's one of our most important, literally finding patients, because the pool of patients for one reason or the other, it's really decreased. So the lecture overview, I just like to introduce a couple of slides about what is PAH, so we have a base of discussion. Then I'll go over the available treatment strategies and the types of current randomized controlled trials that led to development of new drugs in pulmonary hypertension. I'll talk a little bit about specific PAH challenges, and then, because it's not only recruitment, it's way more than that. And then we'll go over the process of recruitment, barriers, and general strategies for improvement, what studies have shown so far. This does not refer necessarily to pulmonary hypertension. It's the literature actually in terms of pulmonary hypertension and research and methodology, and it's very scant, unfortunately. And a couple of pulmonary arterial hypertension dilemmas and unanswered questions, if we have time at the end, that also can impact in actually undergoing research and clinical trials in these patients. So we don't call pulmonary hypertension anymore primary and secondary. We have 5 categories because the pathophysiology of this increase in the pulmonary pressure differs from one to the other category, and also treatment differs. And what we do have treatments for, we have studies and treatments for, it's PAH. This is pulmonary arterial hypertension. So this is a disease that people think it's a lung disease because it starts with pulmonary. Well, in reality, it's not only a disease of the pulmonary vessel, but it's mostly a disease of the right heart. The right, so this is the cross-section in the small pulmonary arterial, which you see this process of proliferation, in situ thrombosis, fibrosis in the adventitia. So the lumen is very much reduced, which increases the pulmonary vascular resistance, increases the afterload to the right ventricle. Patients are not short of breath and they don't die because of this process of proliferation. This is the root of the evil. Would be good if we actually can reverse this process. Would be good if actually we can at least halt the process. And we actually do not have clear evidence for our trials that we are doing much about this. And then the problem that actually leads to symptoms, which are symptoms of heart failure actually, and patient's demise is the problem of the right ventricle that fails. So we need to address both of these issues with our therapies and with everything what we're doing. And I submit that probably this is a bigger emergency than addressing pulmonary arteriopathy. That would probably lead to a cure if we would be able to fix that problem. Now, pulmonary hypertension is a progressive disease with very poor survival. We all know that. This is data from the 80s, late 80s, early 90s, when they had this NIH-sponsored registry of pulmonary hypertension. There were 188 patients with idiopathic pulmonary hypertension. That time they used to call this primary, so pulmonary hypertension without a definite cause. And as you see here, the life expectancy is in the 2.5 years. And 5-year survival, it's in the 20s and 30%. So I think I convinced you that we are dealing here with a very bad disease, as bad as some cancer, worse than some cancers. And we actually do not have any, except for this medication, we do not have any drugs that have been shown to improve survival. And this is only 12-week trial. So what I know about survival in pulmonary hypertension, that in a controlled, it's not random, I mean it is randomized, it is controlled, it wasn't blinded though, because this medication, it's a prostacyclin that's given intravenously 24/7, and they did not consider ethical to put the control arm in, to put the Hickman and to deliver the medication. So patients were randomized. 40 patients have received conventional therapy, that's anticoagulation, calcium channel blockers, and
diuretics, while 41 patients have received epoprostenol. At 3 months, 7 patients died here. And that's the only thing I know about survival in pulmonary hypertension really with certainty. I know that at 3 months, epoprostenol improves survival. I have no clue what's happening down the road. Or at least I don't have controlled evidence of what's happening down the road. We have various ways now at looking at these patients, because given this very high mortality, it's very hard to actually design a study now to, ethically it's hard to design a study with survival endpoint, number one. Number two, you would need a huge amount of patients, which we'll go over. And we really don't have that. I mean, the prevalence and the incidence of the disease is not that high. But what are we doing? We are coming up with all sorts of registries, and this is the French registry that shows that the observed survival nowadays in the year 2000 and plus, when we do have some medications available, it's better than the predicted by the survival predicted by the NIH registry. And we can attribute this this improvement to any of the drugs, specific drugs that we have available. It's probably that we know better how to treat right heart failure. Yes, medications by itself, actually meta-analyses have shown the same thing. None of the specific medications, except for the intravenous epoprostenol, intravenous prostacyclin, does improve survival. None of the other medications that we had developed, it's per se in itself improving survival, but overall survival in the pulmonary hypertension population has increased some. And again, it's probably using the drugs, anticoagulating maybe more, perhaps knowing how to deal with right ventricular failure and so forth. So this is a historical overview of the treatments that we have available. Epoprostenol, that intravenous medication that we mentioned before, has been approved in 95 based on exactly that trial of 81 patients. That's all what FDA needed. And then these are the drugs that have been available in the pulmonary hypertension community. This is the first oral medication that we had available. Then we started to have analogs of prostacyclin, such as treprostinil and iloprost. Now, epoprostenol, fine, is a great drug. It does improve survival, at least at 3 months, we know that. But it does have a couple of problems. On top of the 24/7 administration intravenously, and if you need to have a central line, that obviously can be associated with line infection and so forth. It's also an issue of half-life. The half-life is 2 to 3 minutes. So if it stops, people may die in 30 minutes. So that's it's a problem, and there are situations when you can't really use it because the patients learn how to prepare their own drug. So let's say you have an encephalopathic patient. Now, pulmonary hypertension, pulmonary arterial hypertension can come be idiopathic, or it can come associated with HIV, with connective tissue disorders, with liver disease. So we do have these patients with portal pulmonary hypertension. If you are encephalopathic and you forget to do your medication, you'll die from that reason. So it's not only a medical decision, it's also a social decision that we have to make when we decide to do this patient. So these analogs of prostacyclin, this is PGI2, is what you and I have in our blood vessels. These are analogs that have longer half-life. So number one, you can give by alternate route, like sub-Q or inhaled. And number two, you don't run into that 30-minute panic zone. And we have a couple of pills. And these are the 3 pathways, because why does pulmonary hypertension appear? Why do we have this increase in the pulmonary vascular resistance from proliferation in the small pulmonary arterial? The pathogenesis is very complex, very complicated, but what we have medications for and we are treating are the abnormalities of the pathways, vascular mediator pathways in the pulmonary arterial. So we have prostacyclin pathway. This is a normally it's a vasodilator, anti-proliferative agent. that we supplement. It's downregulated in pulmonary hypertension, and we supplement with these prostacyclins. And overall, at least by the treprostinil data, we think that this is, at least when it's administered continuously parenterally, that's probably the strongest class of drugs we have. Then we have the PDE5 inhibitors, sildenafil and tadalafil, that are working on the nitric oxide pathway. And then we have blockers of the endothelin, bosentan and ambrisentan. All these are pills. So how do we treat this disease? We have this very small percent of people that you can normalize the hemodynamics, so you can decrease the pressure to normal in the cath lab. You have to test for that. And we know that they are eligible for oral calcium channel blockers, and they do very well. If they are true vasoreactors, the survival is 90% at 5 years. Compare that to about 60% with treatments. So it's significant. If they're not vasoreactive, and this is the majority of patients that we have, we know for sure that if they are high risk of progression, they have severe disease, functional class 4, right heart failure. The hemodynamics show certain numbers in the cath lab that signify progression of the disease. Then we know that your first choice would be, recommendation 1A would be epoprostenol or treprostinil, so prostacyclins intravenously. If they're at lower risk, so this is the average patient that we are going to see, it's nothing that tells us exactly how it's going to be the strategy of treatment. What we're doing, most of us nowadays, is so-called goal-directed therapy. So you start with a pill, and nobody tells you which is better. Should I use a PDE5 inhibitor, or should I use endothelin receptor antagonist? And then you follow up the patients every 3-4 months, trying to reach some goals in terms of the walk distance. 6-minute walk distance has been the primary endpoint in all these trials. FDA loves it. It does show that it has some correlation with prognosis, with survival, both at baseline and after treatment. But again, we don't know how is that translating in long-term data and long-term outcomes. So it's for better or worse, this is what we have. This is what we are looking for. We are trying to improve a little bit the outcomes to look at more meaningful endpoints, but this is what we have so far. So you have some criteria, which again are not very clearly stated, but you have some idea. It's a lot of art, unfortunately, and less science. You have some criteria to decide when the patient is doing well and you need to add, you leave them alone, or they're not doing so well and then you need to add medication. And then what you're adding, it depends on the practice. Some people add inhaled prostacyclins or subcutaneous prostacyclin, depending also on the worsening of the patient. Other people add another pill and then the prostacyclins. And the patients, obviously, this is a progressive disease without cure. Patients are going to progress further and further and further. Intravenous prostacyclin transplant and so forth. That will be the progression. So that will, it's the idea is the way we are, most of us, treating these people, by goal-directed therapy. And overall, it does improve survival compared to the NIH registry survival predicted by their equation. However, it's a new trend nowadays to actually start early with a lot of medication. Like I made this comparison with cancer by survival. Also, this proliferation, apoptosis at the level of the small pulmonary arterial. All these things, in a way, make an easy comparison with cancers. So we were looking at the same paradigm to use all medications, the strongest one at the beginning, like an induction phase, and then maintenance phase, trying to cut them down. But we are still learning, but that will be another trend that it's at least discussed about. Or to randomize people in goal-directed therapy versus a triple upfront combination. Triple, because these are the 3 classes that we are treating. And I think the reason for which we don't cure the disease, amongst others, is that probably we are not addressing the right pathway. We are not addressing the problem. We are addressing just the tip of the iceberg. But I have SMAD abnormalities. I have TGF abnormalities, receptor abnormalities. We have been looking actually at other ways of treating this disease, including Gleevec. Yeah.
You don't have to have lung transplant. Is lung transplant an option for pulmonary hypertension?
Yeah, lung transplant, it is an option. It's over here.
Oh, I'm sorry.
Yeah.
Yeah, it's when everything fails. Yeah, we do have that one. Technically, if you don't have them on intravenous, a transplant center wouldn't even talk to you. Because life expectancy 2.5 years not treated, 7.5 years treated. So, and as you know, transplant is another incurable disease, so you kind of try to hold off with that one until you really gain survival benefit. They look at survival when they judge. Yeah. So these randomized controlled trials that happen in pulmonary hypertension that led to that development after 2001 onward are based on placebo-controlled trials of 3 to 4 months duration. It's not considered ethical to keep people, with one exception that I'm going to talk about, is not considered ethical to keep people in a placebo arm for longer than 3-4 months. And even that one is going to be disputable, and I'm going to show a couple of slides about that one too. We do gain information by long-term extension from the patients that were enrolled in the trial. We do have an escape mechanism. If you do worse, then you're taken off the trial and you're given through medication, or you're given, if you're in the placebo arm, you go in the active arm and so forth. It depends on the study. A 6-minute walk test is primary endpoint. We look at symptoms, and this became a surrogate of survival, time to clinical worsening. So yes, we can't really do survival trials in pulmonary hypertension nowadays, but let's find a way of looking at worsening of the disease and quantifying that. Unfortunately, there's no uniformity about the trials. They don't define the same way. So it's, at the end of the day, I'm comparing apples with oranges. I'm comparing apples with oranges anyway because I don't have head-to-head trial and it's not going to happen. And also, if you remember this historical perspective slide. So obviously, right here in 1999, 2000, this is when the bosentan trial was happening. The only option was really the intravenous epoprostenol. Patient population that's been studied here is definitely sicker, even though you define them functional class 3, for example. But this is not a very specific term. What is functional class 3 for me could be 2 for you or 4 for you. So it's not a very specific. So we define them. We look even in hemodynamics, and they kind of seem similar. But I very much doubt that patients that were enrolled and the pool of selection of the patients, the population that we selected patients when we did the bosentan trial, is similar with the ambrisentan trial. When you had already 2 pills available and you had other formulations and so forth on top of the intravenous epoprostenol. And when also the general practitioner is giving Viagra right and left to the patients, without even making the right diagnosis. To make the right diagnosis, you have to do a right heart catheterization. Echocardiograms are not enough. So, and there were a couple of situations when, we had people that were not treated properly and started on medications that, number one, have some toxicity. For example, bosentan can affect the liver function. So they have some toxicity, drug interactions, and they are very, very expensive. This one is $106 wholesale price per pill, and you take 2 a day. So it's not making the right diagnosis. And the general practitioner, well, I got an echo, shows pulmonary hypertension on it. Why do I need to refer them to a tertiary referral center when I can treat them very well in Suffolk County? And we had patients like that, treated inappropriately and so forth. Or the other way around, people with true disease that are left on the pill to progress, and then when they come to you, it's beyond the level of fixing. And we actually started to have already literature about that. Okay, so which are our specific problems? Low incidence, not that are reducing the pool of participants in trials. So far, I think we realized that we need a better treatment. And yes, we looked at Gleevec, and in patients with severe disease, it does work, for example. We looked, or we are trying to look in Montreal now and in Toronto, we're looking at progenital endothelial cell treatments. We're looking at genetics. But we are still at the very, very beginning of actually learning and doing something effective. Reduce patient referral and referral pattern. And referring for studies is very difficult to do. Referring for clinical care, because usually I recruit from my own pool of patients. It's also because they are the referral is reduced for clinical reasons. Of course, is going to be less number of patients to enroll in the trial. Disease has high morbidity and high mortality. And that implies, as we discussed, the duration of the trial, the type of endpoint. We are trying now to change this paradigm of 6-minute walk. We do include 6-minute walk because FDA likes it, and if you don't hit the 6-minute walk, they don't approve it. But what we're trying to do, we're trying to change from a fixed duration of the trial to outcome-derived trials or outcome-driven. So if you worsen whatever arm you are in, that's considered the endpoint. From there on, you either stay in the the drug or you don't, but you're open label right now. And then you compare how fast actually the placebo versus the treated arm reaches this clinical worsening. Again, that's defined various ways. We do have alternative options for therapy, for good or for worse. So we have different patient population that we are looking at, as we discussed. They are competing studies, and I do have about 4 to 6 studies at the same time. At least 2 of them compete for enrollment. And then the marketing effect of the drug companies that go around the city telling them, and around the country telling them that we have drugs, what do we need to refer patients to, why do we need to study this, and so forth and so on. Of course, they want to sell the drug. A recruitment process. So I'm done with pulmonary hypertension. We'll discuss a little bit about recruitment in general. Low participation rates in many trials. In the mid-90s, they have looked at that, and anywhere from 3% to a quarter of the studies that they looked at, they had real issues, including the trial just didn't take off because of recruitment problems. In 2000-2001, it's been a survey of corresponding authors in the British Medical Journal and Lancet, and 60% of the trials had problem recruiting to the target number, or they had to extend the recruitment period below and above what was initially planned. Rarely we're publishing reports in the barriers to recruitment, which were the problems, or if we report them 15 years later. Very little is known at a scientific level about public attitudes, general patient and general public attitudes towards research. And sometimes their attitudes are not very alluring and not very helpful in doing this clinical research. Of course, we have a lot of complexities and extent of required recruitment efforts that might be underestimated. Longer duration, overestimated pool of participants, and fewer participants completing the trial because of multiple other reasons. So this is the Lasagna law. So Dr. Lasagna was actually born in Queens, grew up in Jersey. He ended up being the dean in Tufts. And he also has reformulated the Hippocratic Oath for modern medicine, and a lot of medical schools are actually using that Hippocratic Oath that he came up with. One of the new ideas that he brought is that you should never be ashamed of actually calling for help when it's above you. It's okay to call a colleague for help, rather than being arrogant and trying to deal with the problem and not. Anyway. The Lasagna rule refers to the fact that when I'm estimating my ability to enroll in a trial, before I start the trial, I'm 100%. I have 1 million patients. Somehow, if the study started, it goes down to about 20%. And then after the study is finished, I can enroll again 100%. I can enroll everybody and their dog in the trial. And this is something that I personally feel every day. Causes of subject loss throughout the study, so other causes for not actually achieving the target number. You have, of course, screen failures, poor adherence to protocol, and the more complicated. I have now a trial of inhaled nitric oxide, which again has to be given because it gets inactivated very fast. 24/7 by a special nasal cannula, goes in the atmosphere, becomes NO2, and that's toxic. And patients literally, they shower, whatever they do, they have to have that one, or else you can put them in heart failure or pulmonary vasoconstrictive crisis. I don't know how many patients are actually going to be able to be enrolled and to be able to adhere to the protocol appropriately. Consent withdrawals and of course adverse effects that events that by the trial protocol requires that you take them off. If we don't recruit, it's bad. It's really bad because it does reduce the power. It causes delay with cost and time extended. Also might affect the generalizability of findings if the standard of care has changed meanwhile. Of course, it maintains a level of uncertainty about the trial findings and the efficacy of the studied medication. And the factors that are impacting recruitment are, as mentioned here, failure of screening, of informed consent or randomization itself, protocol criteria too strict, too complicated, competing clinical trials, site motivations, and investigators' capabilities. I don't know about you, but I had a time in my life when I absolutely had just one secretary. I have about 350 chronically critical ill patients to take care of. I had one secretary. She's a supra secretary. She's awesome, but still I had no nurse, and you need a clinical nurse at least to get approved these drugs. You know, someone to be on the phone with the insurance company to get the $1,000 drug approved and so forth. And as you know, everything now requires pre-authorizations and so forth and so on. So I had no one, not talking about research. That would have been a supra luxury. So I used to be my own clinical nurse, my intravenous hypoprostenol nurse, because when they are on, these are given by pumps, so they're in the hospital, you have to have a nurse that knows how to use the pumps. And I was my clinical coordinator. I even have a diploma of, the best enrollment in one of the ambrisentan, the site with best enrollment in the ambrisentan trial, one of them, the landmark trial. So yeah, investigators' capabilities, and if I'm stretched beyond belief and I'm doing research at 2 a.m. or weekends, it becomes a real issue. Subjects distrusting clinical research and true ethical concern, because as we'll see, money talks. So if you give people money, actually they're more willing to get enrolled. And then we can discuss about compensation and specific situations. That's kind of mentioning the same issues that we mentioned. They are clinician-based issues and they are patient-based issues. You have to, how do you do this? How do you recruit patients? We have, again, not much literature. We have a couple of meta-analysis and systematic reviews that we are going to go fast over. So you got to identify sources of patients. You have to request referrals from physicians, and I don't know how successful that is, but there are a couple of ways around. To contact and screen the patients and appropriate it and to obtain informed consent. And literature somehow can guide us more or less, and I'm going to mention what they found to be working and what they didn't find to be working. Couple of strategies like having registries, occupational screening, mailing, media. When you plan and recruitment, pilot studies always help in terms of determining the length of the trial and determining the sample size. Yes, you have to have systems of projecting and monitoring, recruiting, training system, have staff that is specifically trained, and both subject and physician attitudes, maybe some education will definitely help. In terms of general practitioners, so that will be my main source of actually getting these referrals, getting patients, not only for general medical care, pulmonary hypertension, but also for trials. Sometimes it's lack of education about the existence and need for randomized controlled trials. So what we are trying to do, we are actually trying to establish personal contact, and I have actually, networks and regular meetings with them. Midweek in the evening, we get together and we go over what's new and so forth and so on. But usually I go back to the people that I know already, which are people that are already referring to me. I'm not going to go and knock at all cardiologists and pulmonologists door in Brooklyn and tell them that, you know, I'm selling pulmonary hypertension treatments here. So it's, yeah, that implies that you already have some contact before. I didn't pay anyone to refer patients to me. And the problems, they are the same that we have discussed. They are, I found that they are actually very much afraid of having the patient stolen. That's one of the, 80% of the times when I am asking them, why don't you refer, this is the reason. Don't work too well, at least not in pulmonary hypertension. Advertising, the clarity of the message probably is not so easy to do it over a 30-second advertisement. You got to really see how you spend your budget, and also it's important how you, that's in general, not necessarily in pulmonary hypertension, how you handle the prospective candidates. Once someone is responding, how you manage to actually get them towards a site, towards informed consent, because as we've seen, you can fail there too as well. When we are recruiting in centers, tertiary referral centers, primary factor in influencing patients' decision to enroll is the recommendation by the PI. They kind of take you seriously and take your advice seriously. But there are also problems that we have. We have conflict between the physician and scientist role. Belief that standard therapy is best. I don't know if I can say that for pulmonary hypertension, but what I'm going through right now is that we have this over-enthusiasm of using the alternative options to epoprostenol. We use that, we do this goal-directed therapy, but what we've seen more and more is that the patients die. They're started late on intravenous. The later you start them, the less good outcome you have. And at some point, we actually have evidence from trials that people that were randomized to the placebo arm, one way or the other, never catch up with the active arm. 2-3 years down the road, they never catch up. So it's a true problem now. I mean, am I going to have another endothelin receptor antagonist that I'm going to trial? They send me a letter, would you like to participate? Do I really want to subject patients to another one? Do I really want to subject patients in a placebo arm? Even if you have patients, because at some point after 2005, we could not do pure placebo-controlled trials anymore. We needed to have background therapy and then placebo versus intervention. Even those people that were on some background therapy never catch up with placebo. So even having background therapy, it's probably not enough. And it's an ethical concern. Another problem that it is, you're not going to enroll patients that are really very sick, because you're going to put them on therapy. As we discussed, when you're high risk of progression, very sick person, you go straight to the CCU on intravenous prostacyclin. So we're not going to know exactly what's happening with the survival short or long term, since we're only recruiting patients that are really not very sick. That by definition, yes, average life expectancy is 2.5, but if you are really early, it's about 7, 8, 9 years. So it's going to be difficult. Study participants, lack of awareness of clinical trials, lack of access to trials, attitude issue regarding or perception of research. They lose control of their life, they're guinea pigs. HIPAA information at the beginning of the AIDS era, clinical trial in AIDS, that was actually, they don't ask me anymore, but I used to have another HIPAA form if I was planning to enroll, or an addendum or something. I was planning to enroll patients that were HIV positive. And most importantly, and this goes for cancers trials, and this goes for diseases with high mortality like pulmonary hypertension. Patients are fearful of the disease progression and or recurrence, and they are afraid of being assigned to the placebo arm, and I'm afraid of that too. In reality, so this is a study that was done in UPenn. They looked at 25 patients. Or 26 patients from their practice, so it's a unicenter trial, monocenter trial. It's actually a questionnaire that they gave to these 26 people that were deemed to be potentially eligible for the trial, because there are a million reasons for which we can't actually enroll patients in the trial. We won't go over those details. And they ask them the following question, or what would be your initial thoughts and reaction if you'd be asked to participate? What would motivate you to participate or not participate, and what would you tell someone that would be approached to participate in a trial? What would you tell them to encourage or to discourage their participation? So, and also they actually had two groups in which they ask patients, well, I'm going to put you in a placebo-controlled randomized trial, but I stop all your medications, so that's pure placebo-controlled design. And then I'm going to leave you on some medications or whatever you're taking, and then I'm going to randomize you versus intervention versus placebo. And as you see, what motivates them and the major themes that appear during interview. They do have a hope for a cure. At least half of them are very altruistic people. They would like to make this world better. They are concerned of the side effects of the experimental drugs. And then in the group that was asked to stop the medications, 80% and above are actually concerned of the disease progression, and it's rightfully so. I agree. And then it seemed to be a very high percent here of 60s and 70s of people that actually consider the time demands and the inconvenience to go back to the clinic and to go back to the center to be evaluated. Usually the follow-up evaluations are done at the beginning, like once 4 to 6 weeks after enrollment, and then we do every 2 to 3 months the reevaluation. So it's time consuming, plus labs and so forth. In terms of the methods to enhance recruitment, there were 3 relatively recent, from 2006 onward, large meta-analysis and systematic reviews that we're going to go over briefly. So if you send some way of pre-warning the patient, you send them a postcard saying that 2 weeks from now I'm going to send you information about the trial, or you leave a message on the answering machine, doesn't work, doesn't increase recruitment. If you give them extra information, again, you send a personalized letter that you sign in blue ink and you have the letterhead from whatever institution, doesn't impress too many people. Doesn't work. If you send them a video explaining them the research process itself, doesn't help. If you call them actually and you explain the informed consent process itself, you actually tend to decrease recruitment, you scare them away. In terms of what works, not having a placebo arm increases enrollment. And if you compare people, so this is a different type of design, which is partially randomized patient preference trial, in which you give them actually the option to be randomized versus having the choice to go on some active therapy. That's been shown to also look at people that are more likely to agree. Consent changes didn't matter if they had to sign in to participate or they had to sign in not to participate in the trial. Opting in and opting out didn't improve the recruitment. Also, depending on the design and the type of the intervention that you study, you can get consent before randomization, after randomization. The timing of the consent didn't, in terms of the timing of the clinical trial processes, didn't change much. And some positive effect from financial incentives, but of course we can run into ethical issues. Same thing in this other meta-analysis, 206, open arm design increases, trained culturally similar people. So there were patients, and that addresses those special situations with minorities, women, and so forth, and being able to talk the language. Hispanic patients that were trained to recruit other patients, so Hispanic patients already participating in the trial had been there, done that. They were compared with non-Hispanic women that were trained, non-Hispanic women that were not trained for recruitment, and Hispanic women not trained for recruitment. Turned out that if you're speaking their language, you're speaking exactly, addressing cultural issues, and you were trained how to do recruitment, you perform the best. Well, makes sense. Also, it's a trial with prostate cancer prevention in black men. They tried various strategies. What actually worked was to get a church-based program in which you endorse the trial and so forth. And this is the only thing that really worked. Questionnaire related to the respective issues. So this is a trial of prevention of injuries. And they send the information about the trial, but also a questionnaire that was evaluating the safety in the house, evaluating various aspects, steps and so forth, rugs, And turns out that if you add the questionnaire that's specifically related to the health issue that you are trying to address, then the response rate it's higher. Yeah, open arm versus blind arm helps. Again, the same thing, consent rates for novel trial design. We discussed about this patient preference. So patients can actually choose if they are going on an active therapy or they are going to be randomized. But if you look at only the subgroup of people that are accepted to be randomized, the percent of participation is the same as if you go straight to a randomized control trial. So I don't know how much that helps. Having a non-inferiority trial, so 2 active arms comparing, actually helps in terms of enrolling. It's one of the strategies that actually we are using. We have now tadalafil, ambrisentan. I'm actually in this trial called Ambition. Ambrisentan, so that's an endothelin receptor blocker, PD5 inhibitor, tadalafil, and the combination of them. So that's one of the ways where, and it's enrolling fairly well. Recruiter differences, turns out that if you're trained, of course you recruit better, big surprise. If the monitor or some person designated by the sponsoring institution keeps coming back and bugging you, doesn't work, and big surprise. If you are a senior researcher, you tend to enroll better than nurses or assistants, but you increase the costs. And internet-based data management and collection, it didn't help with the recruitment. It did help actually with the management of the data later during the trial, but didn't help with the with enrollment. Incentives, money talks, shown in prevention trials, shown in treatment trials. Now they say that you have to increase the, you increase recruitment only if you're able to increase the incentive from $200 or $100 to $2,000 per patient. I don't pay them $2,000. I mean, they get at least $50 to $75 to pay for the cab or for the subway and whatever, the train. So I don't know who's giving $2,000 to the patient for participation, not even if you add the visits. And another thing that they found important in this, this is the latest systematic review from 2010. If you actually call them or send them a pamphlet or send them a video, not about the consent process, the clinical trial procedures, whatever, just educate them about their disease. If you do that, actually, they tend to develop those altruistic capabilities, or they are more concerned about finding a cure and so forth and so on. So they know what they're talking about, and then educating them did improve recruitment. We have 5 more minutes, and I have some other aspects that we kind of touched upon during the rest of the talk. I'd rather stop here, and that's the summary slide. So we have to educate potential participants and referring physicians to the best of our ability. To try to do, and I don't know how exactly, to try to establish trust in medical research, because if people think they're guinea pigs, it's counterproductive. And of course, there are specific patient population, specific diseases that we have to take into account and consider separately. Yes, we have issues with resources and support for clinical research, but there are some effective recruitment strategies, such as educating the person about the disease, maybe to a certain extent the finances, maybe trying to avoid placebo arms, finding a scientific way of getting some data without, the placebo arm. And I think I'll stop here. There are 5 more minutes, so if anyone has any